talk about the top 10 ICU nutrition studies really coming right out of the Patel and McClave New England Journal of Medicine review, so that it's really up to date, July 9th, 2026. So the first paper is EN versus PN. We're looking at calories trial, Nutriurea 2, and the meta-analysis in 2024. So let's look at calories, 2,400 patients, early PN versus early enteral nutrition. Should you do parenteral IV nutrition or feed the gut? 30-day mortality was identical. There were more GI events with enteral nutrition. Nutria 2 was more of a ventilated shock patient. 28-day mortality was identical. The enteral nutrition is 2% bowel ischemia versus less than 1% with parenteral nutrition. And then a meta-analysis in 2024, 14 trials, showed that early enteral nutrition had fewer systemic infections and shorter ICU hospital stay, more vomiting, diarrhea. Early PN was safe alternative when enteral nutrition is contraindicated. So enteral nutrition is preferred, but early parenteral nutrition is not inferior and is safer in shock. That's really the takeaway there. So the enteral nutrition preserves your gut integrity and microbiome, but in shock patients, early full dose enteral nutrition can cause some bowel ischemia. So you start low or use parenteral nutrition until the shock is resolving. So again, early PN is not necessarily inferior and is definitely safer in shock, as we saw in the Nutria 2 Lancet 2018 paper. Number 2, the Eden trial, trophic versus full dose in EN, enteral nutrition, in ALI, ARDS. Less is more in early ALI, ARDS, and you don't push the calories. This is 1,000 patients, multiple ICUs, ventilator-free days, and 60-day mortality is what we're looking at. In the trophic group, that was 10 cc's per hour, about 400 kilocalories a day. Full dose group is 1,300 kilocalories a day. The trophic group had fewer GI complications, less vomiting, less constipation, lower gastric residuals, whereas the full dose group had more GI complications, more vomiting, more constipation, higher gastric residuals. The trophic 10 cc's per hour is non-inferior. There was, remember, no difference in ventilator-free days, no difference in 60-day mortality. It avoids the GI harm. So you don't push calories in the early acute phase of ALI/ARDS. The PERMIT trial is the permissive underfeeding versus the standard dose. This is New England Journal of Medicine Arabi trial in 2015, looking at 894 patients. Underfeeding is 40 to 60% calories versus the standard, 70 to 100%. There was an identical 90-day mortality, basically 30% versus 35%, which was a p-value of 0.09. If anything, the lower dose calorie had a better mortality, but there was no difference in the ICU mortality. There was the 40 to 60% had no harm, restricting the calories while maintaining protein. Again, the caloric restriction did not mean protein restriction. So restricting calories is safe and possibly beneficial early, but restricting protein is the error to avoid. Maintaining protein while holding back energy, especially in the first week. So you could safely underfeed calories without harming outcomes. And again, you want to maintain protein while holding back the energy. The next trial is Nutria 2. We touched upon this already in the first trial. Again, ventilated adults with circulatory shock and vasopressors, 2,410 patients in France. Almost half of them were on norepinephrine greater than 0.5 mics per kilogram per minute. 28-day mortality, there was no difference in early PN versus early full dose EN, but the bowel ischemia was higher in the full dose EN in shock patients, which caused intestinal infarction. That was real harm. GI adverse events, GI complications were more frequent in the enteral nutrition. Why this happens? Vasopressors reduce mesenteric blood flow. Gut walls already ischemic in shock. Aggressive EN increases oxygen demand on an already hypoperfused gut. So you shouldn't push full dose enteral nutrition into a shock gut. Bowel ischemia risk is real. So you should start low. So you should either do low dose enteral nutrition or use parenteral nutrition until the shock is resolved. And we went over that in point number 1. Nutriurea 3, which is the low versus standard calories in ventilated shock patients. So in shock, you should start at 6 kilocalories per kilogram per day, not 25, and you should advance as shock resolves. This is a Rainier et al. Lancet Respiratory Medicine 2023 trial. Looked at ventilated adults with circulatory shock, 3,000 patients. Again, the low-calorie enteral nutrition had shorter ICU readiness for discharge. Primary outcome was met. And the standard had longer time to ICU readiness. There was no difference in 28 or 90-day mortality. The standard 25 kilogram per kilocal per kilogram per day caused more GI complications. So the Nutriurea 2 showed full dose EN caused bowel ischemia and shock, and then the Nutriurea 3 now quantifies the right starting dose, which should be 6 kilocalories per kilogram per day, trophic, and you should advance slowly only as shock resolves and vasopressors are weaned. So in shock, you should start at the trophic feeding dose. Standard dose EN in shock causes more GI harm, and you should advance slowly as the shock resolves. Okay, what about caloric restriction in refeeding syndrome? So that is paper number 6. Refeeding syndrome kills, slow ramp, 91% versus 78% survival. This is critically ill adults with low phosphate on initiation of feeding, 339 patients. So either you did a slow ramp up, which is 20 kilocalories per hour times 2 days, then gradual advance, or you would do a rapid full caloric intake, and it looked like there was a definite significant 90-day survival with the slow ramp up. 21 versus 28 days of hospital stay. Infection rate was also lower. 13 out of 100 patients will die if you feed fast. So if hypophosphatemia develops on initiation of feeding, you should stop or restrict calories, give IV thiamine, monitor your phosphate, mag, and calcium and potassium every 6 to 12 hours. Slow ramp up once phosphate is normalized. This is life-saving. So the point of this trial is that refeeding syndrome kills. And if low phosphate develops on initiation of feeding, you should restrict the calories, give thiamine, and again, monitor every 6 to 12 hours your micronutrients. And the slow ramp should be 91% versus 78%, 60-day survival. The next trial is the energy dense versus the standard formula in critically ill. Target investigators, New England Journal of Medicine, 2018. So more calories do not improve outcomes. You should stop chasing the caloric targets. Here we're looking at the largest enteral nutrition dose trial ever conducted. We're looking at 1 kilocalorie per ml versus an energy dense. There was no mortality difference. The extra calories delivered were about 500 kilocalories per day. There was no ventilator-free days, ICU stay, increased GI events in the higher density formula. This really settles the more is better debate. Delivering 500 more kilocalories per day did nothing for patients, caused more GI harm. So stop adjusting the nutrition to hit caloric goals. Again, more calories do not improve outcomes in critically ill patients. Energy dense formula increases GI complications without a mortality benefit. Interestingly, it didn't worsen mortality, but still, you should stop chasing caloric targets. Paper number 8 is Effort Protein, Lancet 2023, Highland et al. We're looking at high dose protein, does it help? And actually, it probably harms patients in AKI. We're talking about high protein, which is greater than 2.2 grams per kilogram per day, versus the usual protein, which is less than 1.2 grams per kilogram per day. There was, again, no difference in 60-day time to discharge, but there was a harm in patients with AKI, not on RRT. They did worse with high protein. So malnutrition, don't fix with protein. They had 2 confirmatory meta-analyses published in 2024. High protein offers no benefit in unselected ICU patients. ESPEN 2023 recommends advanced protein gradually to 1.3 grams per kilogram per day during the first week, but not greater than 2.2. Again, high protein does not improve outcomes and harms patients with AKI, not on RRT. Your target should be 1.2 to 1.5 grams per kilogram per day. The number 9 trial is the precise and target protein confirmatory, confirming the effort. Protein dose debate is settled. High protein does not help and harms quality of life. This is mechanically ventilated ICU adults, 935, Australia, New Zealand. Precise trial in Lancet 2024 looked at 2 versus 1.3 grams per kilogram per day. The high protein group had more GI adverse events, lower health related quality of life, whereas the target protein, JAMA 2025, 100 grams per liter protein dense formula versus the 63 grams per liter. There was no difference. No subgroup benefited from the high protein. So more GI harm, worse quality of life, worse AKI outcomes. So again, you advance to 1.3 grams per kilogram per day. Look how many patients they had in the target protein trial. Protein, more is not better. And then the paper number 10, which is really a compilation of 3 trials to show that you should stop checking gastric residuals. There are 2 randomized controlled trials and 1 meta-analysis. So the Regain ICM 2010, 329 patients, looking at residual volumes 500 versus 200 cc threshold. The higher threshold decreased complications, increased in feeding delivery, no difference in pneumonia mortality. Nutria 1, JAMA 2013, there was no monitoring, had more feeding hours, and there was no difference in VAP, mortality, ICU length of stay. And the largest meta-analysis on this, 7 trials, showed that there was no increase if you stopped, if you were monitoring the residual volumes in terms of VAP, ICU length of stay, and mortality. So when you should stop enteral nutrition is dependent on bowel ischemia, infarction, abdominal compartment syndrome, active upper GI bleeding, frank obstruction, but not high gastric residual volume. And then the 4 more studies that we should be aware of are the EAT ICU, early goal-directed nutrition guided by indirect calorimetry. There was no difference in clinical outcomes. The revised stress ulcer prophylaxis was showed that enteral nutrition was protective against upper GI bleeding, and it supports the continuation of EN even in patient at risk of GI bleeding. SCCM glycemic control guidelines 2024 showing that the target blood glucose less than 180 in critically ill adults. Full dose nutrition showed more hypoglycemia and insulin requirements. And then you should know the guidelines, ASPEN 2016 and ESPEN 2023 nutrition guidelines. We went over the protein recommendation. You should avoid gastric residual volume and restrictive caloric strategy early. So the top 10 trials, again, calories plus Nutria 2, basically showing enteral nutrition versus parenteral nutrition. Mortality is identical. The Eden ARDS trial, permit, showing underfeeding in terms of energy, but not protein. Nutria 2, that was the ventilated patients in shock. Bowel ischemia is real. Nutria 3 confirmed that you should be using trophic feeding in the shock patients. Refeeding syndrome target showing more calories do not improve outcomes. Effort protein showing AKI harm with greater than 2.2 grams per kilogram. Precise and target protein showed again similar, that the quality of life was worse with high protein. And then the last 3 trials showing that gastric residual volume is out. Great. Done for the day.